Hello, this is Dr. Ruby, and welcome to the first lecture for Module 3. Today we will discuss the joints of the lower extremity. For those of you that are interested in using the resources on the Evolve website, please contact me by email. That's romaniruby@calu.edu, and let me know your course section so that I can send you back where you can access that information. You basically need to register there with the resources, and these would be extra activities to help you study for the quizzes. So in the first part of the chapter, we have these objectives listed. Remember, you want to use these objectives to help you study for the quiz. These are the items that we'd like you to know after reading the chapter and studying this lecture. Again, here's further objectives for you, and I do have the Evolve student portal link there for you, but again, please email me at romaniruby@calu.edu. Let me know your section number, and I can assist you in getting into that Evolve website area if you have not done so already. In this lecture, we will discuss the joints of the lower extremity listed here: the symphysis pubis joint, the sacroiliac joints, the lumbosacral joint, the hip joints, knee joint complex, and the tibiofibular joints. We will also discuss the patellofemoral joint, the tarsal joints, the tarsometatarsal joints, the intermetatarsal joints, the metatarsophalangeal joints, and the interphalangeal joints. Let's start with the pelvis. The bony pelvis comprises the sacrum, the coccyx, and two pelvic bones. It is considered a transitional body part because the two pelvic bones belong to the appendicular skeleton, while the sacrum and coccyx belong to the axial skeleton. Being a separate body part from both the trunk and the thighs, the pelvis moves relative to the trunk at the lumbosacral or L5-S1 joint and relative to both thighs at the hip joints. Given that bones with the pelvis are also separated by joints, motion within the pelvis is also possible. This motion is called intrapelvic motion. Intrapelvic motion happens at the symphysis pubis joint between the two pubic bones, and at the sacroiliac joints between the sacrum and the iliac portions of the right and left pelvic bones. The type of motion possible at the symphysis pubis is a non-axial gliding movement. The muscles of the abdominal wall and the medial thigh stabilize the symphysis pubis joint. These muscles include the rectus abdominis, the external and internal abdominal obliques, the transversus abdominis of the anterior wall, and the adductor longus, gracilis, and adductor brevis of the medial thigh. There is some disagreement on the movement and the importance of SI motion between chiropractors and osteopaths. They believe that the SI joint is perhaps the most important joint of the low back. It is important to the chiropractic and osteopathic practitioners because it allows motion between the right and left sides of the pelvis. And a lot of the low back pain that people experience is actually sacroiliac joint pain. When we look at the SI joint, it allows a non-axial gliding and axial movement of nutation and counter-nutation. During nutation, the superior sacral base drops anteriorly and inferiorly, while the inferior tip of the sacrum moves posteriorly and superiorly, tilting the pelvic bones posteriorly relative to the sacrum. During counter-nutation, this motion is reversed, tilting the pelvic bone anteriorly relative to the sacrum. The sacroiliac joint is unusual in that it begins as a diarthrotic synovial joint, allowing an appreciable degree of movement. However, as a person ages, the tremendous weight borne by the joint causes fibrous tissue to be deposited into its cavity to help stabilize the joint, thus converting the SI joint into a fibrous amphiarthrotic joint. There are several ligaments in the SI joint. There are two ligaments, the sacrotuberous and the sacrospinous ligaments, that do not attach directly from the sacrum to the ilium, but they do provide indirect stabilization. The SI joint is affected by the forces from both above and below. Weight-bearing forces push downward from above, while forces of impact, walking, running, and jumping, travel upward to the joint through the femurs. During pregnancy, the ligaments of the SI joints loosen to allow passage of the baby through the birth canal. The looseness tends to remain throughout a woman's life, decreasing the stability and increasing the predisposition to low back problems and pain. Although the lumbosacral joint allows only limited motion, the pelvis can anteriorly and posteriorly tilt in the sagittal plane around the mediolateral axis. To move beyond the few degrees of motion allowed, the trunk must move in union with the pelvis. This movement is called lumbopelvic rhythm. The pelvis can depress or elevate on one side in the frontal plane around an anterior-posterior axis. Elevation of one side of the pelvis at the lumbosacral joint is always accompanied by depression of the other side of the pelvis. When no motion occurs at the hip joints, movement of the pelvis at the lumbosacral joint changes the orientation of the lower extremities. When this happens, the thighs are said to be going along for the ride. The pelvis can rotate to the right or the left in the transverse plane around a vertical axis. Movement of the pelvis at the lumbosacral joint is an example of reverse action because people must often think of the trunk moving relative to a fixed pelvis rather than the pelvis moving relative to a fixed trunk. The pelvis can tilt posteriorly and anteriorly in the sagittal plane around a mediolateral axis. When the pelvis tilts and no motion occurs at the lumbosacral joint, the upper body changes its orientation. When this happens, the trunk is said to be going along for a ride. The pelvis can depress or elevate on one side in the frontal plane around a vertical axis. When the pelvis elevates on one side, it depresses on the other, and vice versa. The pelvis can rotate to the right or to the left in the transverse plane around a vertical axis. It is possible for the pelvis to move at both hip joints at the same time, resulting in the pelvis changing position relative to both thighs. If the pelvis moves relative to only one hip joint, the other thigh stays fixed to the pelvis and goes along for the ride. Above are the average ranges of motion of the pelvis at the lumbosacral and hip joints, described when a client is seated with thighs flexed at 90 degrees at the hip joint. A client standing or with knees extended would show a different range of motion. When motion occurs at both the lumbosacral joint and the hip joints, the pelvis moves relative to both the spine and the thighs. When the pelvis moves at both the lumbosacral joint and the hip joints, it changes its position relative to both the spine and the femurs. When the pelvis approaches its maximum range of movement at the lumbosacral joint, motion also occurs at the lumbar spinal joints, changing the lumbar spinal curve. Pelvic spinal movement at the lumbosacral joint is possible within each of three cardinal planes: sagittal, frontal, and transverse. Pelvic movements can be understood as the reverse actions of the muscles that cross the lumbosacral joint from the trunk to the pelvis. During pelvic spinal movement in the sagittal plane, anterior abdominal wall musculature tilts the pelvis posteriorly and or flexes the trunk at the lumbosacral joint. Some of the muscles of the anterior abdominal wall that posteriorly tilt the pelvis and or flex the trunk at the lumbosacral joint include the rectus abdominis, the external abdominal obliques, and the internal abdominal obliques. The paraspinal musculature tilts the pelvis anteriorly and or extends the trunk at the lumbosacral joint. Some of the muscles of the paraspinal musculature that anteriorly tilt the pelvis and or extend the trunk at the lumbosacral joint are the erector spinae group, the transversospinalis group, the quadratus lumborum, and the latissimus dorsi. During the frontoplane actions of the pelvis and trunk at the lumbosacral joint, the right pelvis is elevated by the same muscles responsible for right lateral flexion of the trunk. Some of the muscles involved here include the right erector spinae group, the right transversospinalis group, the right quadratus lumborum, and the right latissimus dorsi. During transverse plane actions of the pelvis and trunk at the lumbosacral joint, the same musculature performs both pelvic and trunk actions. Some of the muscles involved in both right rotation of the pelvis at the lumbosacral joint and left rotation of the trunk at the lumbosacral joint include both left-sided ipsilateral rotators of the trunk, the erector spinae group and the left internal abdominal oblique, and right-sided contralateral rotators of the trunk, the right transversospinalis group and the right external abdominal oblique. Pelvic thigh movement at the hip joint can be considered the reverse action of the muscles crossing the hip joint from the pelvis to the thigh. These movements cross three planes: sagittal, frontal, and transverse. During pelvic thigh movement in the sagittal plane, anterior tilt of the pelvis at the hip joint and flexion of the thigh at the hip joint are performed by the same anterior muscle group. The most common muscle here would be the rectus femoris, and it would be involved in both moving the thigh upward toward the pelvis or the pelvis downward toward the thigh. Posterior tilt of the pelvis at the hip joint and extension of the thigh at the hip joint are performed by the same posterior muscle group. This would be the extensor muscles. The extensor muscles of the hip move both the pelvis downward posteriorly toward the thigh and or the thigh upward posteriorly toward the pelvis. A good example of this muscle group would be the hamstrings and the gluteus maximus. During pelvic thigh movement in the frontal plane, the same muscles perform both depression of the right pelvis at the hip joint and abduction of the right thigh at the hip joint. These muscles include the abductor muscles of the right hip that move both the right thigh laterally toward the right side of the pelvis and or the right pelvis laterally down toward the right thigh. Elevation of the right pelvis at the hip joint and adduction of the right thigh at the hip joint are performed by the same medial group of muscles. This is the hip adductor musculature. Note that the pelvis largely moves as a unit, so elevation of the right side of the pelvis depresses the left side of the pelvis. The muscles involved, therefore, are ipsilateral elevators of the pelvis. Pelvic thigh movement in the transverse plane results from the action of posterior and anterior groups of muscles. The posterior group is often called the lateral rotators of the hip, and these perform lateral rotation of the thigh at the hip joint, as well as contralateral rotation of the pelvis at the hip joint. The anterior group is often called the medial rotators of the hip joint. These medial rotators perform ipsilateral rotation of the pelvis at the hip joint and medial rotation of the thigh at the hip joint. On these slides, please notice additional objectives. These are the objectives for Lesson 8.2 in your textbook. Again, you want to use the objectives to help you study for your quiz. You want to read through them and make sure that you can understand and describe the objective so that you do well on the quiz. Here's a second slide of objectives. The sacral base angle measures the anterior tilt of the sacrum. Because the spinal column sits on the sacral base, any change in its angle affects the posture of the spine. A tilt angle of approximately 30 degrees is considered normal. Lumbopelvic rhythm refers to the relationship between the posture and movement of the pelvis and the spine. The righting reflex refers to the body's instinct to bring the head to a level position. This is one of the purposes of the spinal column, and it helps ensure proper balance, hearing, and vision. A sacral base angle of 15 degrees, as in Figure A, is less than normal and results in a decreased spinal curve. A sacral base angle of 45 degrees, as in Figure C, is greater than normal and results in an increased curvature of the lumbar spine. If the sacral base were perfectly level, the spine could be totally straight and the head would be level. Because the sacral base tilts, the spine, obeying the righting reflex, curves to bring the head to a level posture. The femur and pelvic bone meet in the ball and socket hip joint that's formed by the femur and the acetabulum of the pelvic bone. All three bones of the pelvic bone, the ilium, the ischium, and the pubis, compose the acetabulum. The hip joint is a synovial joint of the subtype ball and socket with a diarthrotic function of the subtype triaxial. The socket of the hip joint is very deep and provides excellent stability. It compares to the shallower glenoid fossa of the shoulder joint by being much deeper and provides for better stability but less mobility than the shoulder joint. Within the sagittal plane, the hip joint allows the axial movements of flexion and extension around the mediolateral axis. In the frontal plane, it allows abduction and adduction around the anterior-posterior axis. Within the transverse plane, it allows medial rotation and lateral rotation around a vertical axis. Reverse actions of the pelvis at the hip joint are anterior tilt and posterior tilt in the sagittal plane, depression and elevation in the frontal plane, and right rotation and left rotation in the transverse plane. On this slide, we'll discuss open chain activities and closed chain activities. Chain activities involve linked kinematic elements such as bones. An open chain allows movement of the distal element. A closed chain does not, requiring that the proximal element moves instead. In a very common closed chain activity, the foot is planted on the ground, fixing its distal end. Within a closed chain, any muscle activity will be a reverse action, meaning the proximal body moves relative to the distal body, reversing the usual action. Instead of the planted foot moving, the leg will move at the ankle joint or the thigh at the knee joint or the pelvis at the hip joint. Flexion and extension of the thigh at the hip joint are axial movements within the sagittal plane around a mediolateral axis. The distal thigh's freedom of movement makes the depicted flexion and extension open chain actions. If the action were closed chain, the pelvis would tilt anteriorly and posteriorly in the sagittal plane relative to a fixed distal thigh. The abduction and adduction movements shown in this figure also illustrate open chain activity in which the distal thigh moves freely relative to the proximal thigh. Abduction and adduction of the thigh at the hip joint are axial movements within the frontal plane around an anterior-posterior axis. Medial and lateral rotations of the thigh at the hip joint are axial movements around a vertical axis within the transverse plane. If the distal thigh were fixed, creating a closed chain, the pelvic movement created by the fixed distal thigh would allow only a reverse action, which in the transverse plane means right and left rotation of the pelvis at the hip joint. This table lists the average ranges of motion of the thigh moving relative to a fixed pelvis at the hip joint. The fibrous hip joint capsule contains strong circular fibers called zona orbicularis that surround the neck of the femur. The strength of this capsule provides the joint excellent stability. As their names imply, the iliofemoral ligament attaches the ilium to the femur, the puberofemoral ligament attaches the pubis to the femur, and the ischiofemoral ligament attaches the ischium to the femur. One of the thickest, strongest ligaments in the body is the iliofemoral ligament. It is important because the body weight of a standing person with extension of the hip joint leans on the iliofemoral ligament. The twisting of the ligaments of the hip joint visible in this figure happen in utero when the femur shaft rotates medially. This twisting causes the ventral surface of the thigh to face posteriorly instead of anteriorly. Importantly, this means that flexion of the leg at the knee joint is a posterior rather than anterior movement. The ligament teres runs from the internal surface of the acetabulum to the femoral head. Rather than adding stability, The ligamentum teres provides a conduit for blood vessels and nerves to the femoral head. Large muscle groups cross the hip joint. The anterior muscles include the iliopsoas, the tensor fasciae latae, the rectus femoris, the sartorius, and the further anterior hip joint adductors. Posterior muscles include gluteals, hamstrings, and the adductor magnus. Medial muscles include the hip joint adductor group. Lateral muscles include the gluteals, the tensor fasciae latae, and the sartorius. The head and neck and shaft that compose the femur do not lie in a straight line. Two femoral angulations exist between them. They are measured by the angle of inclination and the angle of torsion. The angle of inclination is the angulation of the femoral head and neck relative to the shaft within the frontal plane. While a normal adult angulation approximates 125 degrees at birth, the angle approximates 150 degrees. This angle is reduced with the stress of weight bearing that decreases the femur's angle of inclination as a child ages. The femoral torsion angle is the angulation of the femoral head and neck to the shaft within the transverse plane. Torsion angles at birth measure 30 to 40 degrees and normally decrease to 15 degrees by age 6. The pigeon-toed walk common among children compensates for this greater femoral torsion. But in-toeing may persist into adulthood if contractures in the medial rotator muscles or adhesions in certain ligaments develop. These angulations of the femur have a special importance because therapists viewing a deviation in an orientation of a client's foot often blame the foot, but it is as likely that changes to the foot orientation reflect deviations in the hip joint and femur. There tends to be a rhythm to how the femur of the thigh and the pelvis move. When the actions of the thigh and the pelvis are coupled to allow greater elevation of the foot in the air, this coordination of movement is known as femoropelvic motion. Femoropelvic rhythm. To kick a ball, the right thigh moves at the hip joint up to its maximum 90 degrees. The coupled action of femoropelvic rhythm increases this range by tilting the pelvis posteriorly at the left contralateral hip joint, thus providing a stronger follow-through for the kick. The ballet dancer increases her range of motion by coupling right thigh extension at the hip joint with anterior tilt of the pelvis at the left hip joint. This slide includes the objectives for Lesson 8.3. Again, use the objectives to prepare yourself for the quiz questions. Now let's look at the knee joint complex. The knee joint is called a complex because its capsule contains more than one articulation. The knee joint's primary articulation is between the tibia and the femur, known as the Tibiofemoral Joint. Generally, when the context is otherwise not made clear, the term knee joint refers to the Tibiofemoral Joint. At the Patellofemoral Joint, the patella articulates with the femur within the same joint capsule as the Tibiofemoral Joint. The Tibiofemoral Joint is classified as a synovial modified hinge joint. Its functional classification is a diarthrotic biaxial joint. The tibiofemoral joint allows the axial movements of flexion and extension around the mediolateral axis within the sagittal plane. It also allows the axial movements of medial and lateral rotation around a vertical axis within the transverse plane. The medial and lateral rotation, however, can only occur if the tibiofemoral joint is in flexion. A fully extended tibiofemoral joint cannot rotate. Figures A and B show flexion and extension of the knee joint, respectively. Lateral rotation and medial rotation of the leg at the knee joint are possible only if the knee joint is flexed and the thigh is fixed. Likewise, when the knee joint is flexed and the leg is fixed, the thigh can rotate at the knee joint. Medial rotation of the leg at the knee joint is equivalent to lateral rotation of the thigh at the knee joint. Similarly, lateral rotation of the leg at the knee joint is equivalent to medial rotation of the thigh at the knee joint. When measuring the average range of motion of the leg at the tibiofemoral joint, extension is expressed as hyperextension in this table because the tibiofemoral joint is fully extended in anatomic position. So, the further 5 degrees of extension are considered to be hyperextension. It should be noted that rotation measurements are taken with the knee joint flexed at 90 degrees. Ligaments providing important stability to the knee joint are often injured because powerful forces are transmitted to the knee joint, which also performs a weight-bearing role. The shapes of the bones of the knee joint provide very little stability. The capsule of the tibiofemoral joint extends from the distal femur to the proximal tibia and includes the patella. Although lax, it is reinforced by many ligaments, muscles, and fascia. The medial and lateral collateral ligaments are found on both sides of the tibiofemoral joint. They are important to limit frontal plane movements of the bones at the knee joint. The medial collateral ligament attaches from the femur to the tibia and limits frontal plane abduction of the leg at the knee joint. The lateral collateral ligament attaches from the femur to the fibula and limits frontal plane adduction of the leg at the knee joint. The anterior and posterior cruciate ligaments cross each other and limit sagittal plane translation movement of the bones of the knee joint. Together, the various fibers of these ligaments can resist the extremes of every motion at the knee joint. The anterior cruciate ligament attaches from the anterior tibia to the posterior femur, where it becomes taut at the end of the range of extension of the knee joint. The posterior cruciate ligament attaches from the posterior tibia to the anterior femur, where it becomes taut at the extreme range of flexion of the knee joint. When learning the cruciate ligaments, it can be useful to think tibia. The anterior cruciate attaches to the anterior tibia and the posterior femur and limits anterior glide of the tibia and posterior glide of the femur. Similar reasoning applies to the posterior cruciate ligament. The most commonly injured ligament of the knee is the anterior cruciate ligament. It is most commonly injured during cutting in sports. It's a combination of forceful extension and rotation with the foot planted when changing direction while running. The major anterior muscles of the knee joint are those of the quadriceps femoris group, the gluteus maximus, and the tensor fasciae lata also aid in extension of the knee joint. The major posterior muscle group is the hamstring group. The heads of the gastrocnemius are also located posteriorly. These muscles flex the knee joint. No muscles move the knee joint medially in the frontal plane, but the sartorius, gracilis, and semitendinosus stabilize the knee joint's medial side. No muscles move the knee joint laterally in the frontal plane either, but the iliotibial band helps stabilize the knee joint's lateral side. Two menisci, medial and lateral, are located within the knee joint on the tibia. Crescent-shaped and fibrocartilaginous, they absorb approximately half the weight-bearing force transmitted through the knee. They also increase the knee joint's congruency and stability. The screw-home mechanism describes the rotation of the knee joint that occurs while completing its final 30 degrees of extension. This action helps to lock the knee joint and increase stability. If the thigh is fixed, the leg will rotate laterally at the knee joint. If the leg is fixed, the thigh will rotate medially at the knee joint. The patellofemoral joint is formed by the articulation between the patella and the femur and located within the capsule of the knee joint along with the tibiofemoral joint. However, the tibia is not directly involved in the movement of the patella. The intercondylar groove shown in the figure indicates that the path along which the patella tracks the femur during its non-axial gliding movement. The posterior articular surface of the patella has two facets. The medial facet moves along the medial condyle of the femur, and the lateral facet moves along the lateral condyle of the femur. The articular surface of the patella has the thickest cartilage of any joint in the body, allowing it to withstand the compressive force of the patella against the femur, as well as the stress that can result if the patella does not track perfectly along the intercondylar groove of the femur. Breakdown of this cartilage, which is common, is called patellofemoral syndrome. It is often repaired with arthroscopic surgery. The patella allows superior and inferior gliding movements along the femur. During this movement, the patella is said to be tracking the femur. Even though the closed packed position of the knee joint is full extension, the patella itself is most stable when the knee joint is in flexion. The major purpose of the patella is to act as an anatomic pulley, changing the line of pull and increasing the leverage and force that the quadriceps femoris muscle group exerts on the tibia. Without a patella, the muscles would lose about 20% of their strength at the knee joint. Because the components of the knee joint, femur, tibia, and patella, are not arranged in a straight line, 3 angles can be measured between them: the genu valgum/verum, the Q angle, and the genu recurvatum. The genu valgum verum angle is the angulation of the femoral shaft relative to the tibial shaft within the frontal plane. Genu valgum is an abduction of the tibia relative to the femur in the frontal plane. Genu verum is an adduction of the tibia relative to the femur in the frontal plane. Genu recurvatum is a hyperextension of the knee. Slight genu valgum is normal because the femur slants inward and in consequence meets the vertical tibia at an angle. Genu valgum angles greater than 10 degrees are excessive and produce knock knees. A genu verum angle at the knee joint is called a bow leg. An excess in either direction increases stress and can damage the knee joint. Various problems of the foot, knee joint, and hip joint can all contribute to increased genu valgum. The frontal plane angulation, called the Q angle, is so named because it measures the lateral angle of pull of the quadriceps femoris group on the patella. A normal Q angle measures 10 to 15 degrees. Men typically measure 10 degrees, but because of the female pelvis is wider, women measure nearer to 15 degrees. An increased Q angle pulls the patella laterally, causing it to ride against the lateral side of the intercondylar groove, which could damage the cartilage of the articular posterior surface of the patella. If the Q angle is greater than 0, it reflects the fact that the quadriceps femoris group pulls unevenly on the patella, showing a bias to the lateral side. One effect of the pull is called a bowstring. Bowstringing includes the lateral pull of the patella caused by an increased Q angle in the figure. Bowstring force is represented by the distance between the center of the patella and the dotted line. The solid line indicates the Q angle. This net lateral pull of the quadriceps femoris group is due in part to the greater relative strength of the vastus lateralis muscle compared to the vastus medialis. Normal full extension of the knee joint produces a hyperextension of 5 to 10 degrees. 2 factors explain why the knee joint hyperextends into the sagittal plane at full extension. The shape of the tibia plateau slopes slightly posteriorly, and the center of a person's body weight when standing falls anterior to the knee joint. Resistance is provided by the passive tension of the soft tissue structures of the posterior knee joint. When this resistance is insufficient, genu recurvatum, or hyperextension, results. Genu recurvatum describes hyperextension of the knee joint beyond 10 degrees in the sagittal plane. The proximal tibiofibular joint is between the lateral condyle of the tibia and the head of the fibula. The middle tibiofibular joint is formed by the interosseous membrane that unites the shafts of the tibia and fibula. The distal tibiofibular joint is created by the articulation of the medial side of the lateral malleolus of the fibula and the fibular notch in the distal tibia. The tibiofibular joints allow non-axial superior and inferior glide motions at the fibula relative to the tibia. The interosseous membrane that unites the shafts of the tibia and fibula allow for the joined bones to grip the talus of the ankle joint between them, making the middle tibiofibular joint vital to the stability of the ankle. It also transfers the forces of the muscles pulling on the fibula to the tibia, moving the leg at the knee joint. Tibial torsion describes the twisting of the shaft of the tibia, which causes the distal tibia and proximal tibia to face in different directions, with the distal tibia facing somewhat laterally compared to the proximal tibia. As a result of lateral tibial torsion, motions at the ankle joint do not occur exactly within the sagittal plane, but within an oblique plane instead. Here are the objectives for Section 8.4. Again, please use the objectives to assist you in studying for the quiz. The foot is defined as everything distal to the tibia and fibula. The bones of the leg articulate with the foot at the talocrural ankle joint. The bones of the foot can be divided into tarsals, metatarsals, and phalanges. The hindfoot region of the foot consists of the talus and calcaneus, which are tarsal bones. The midfoot consists of the navicular, cuboid, and 3 cuneiforms, which are tarsal bones. The forefoot consists of the metatarsals and phalanges. The term ray refers in the foot to a metatarsal and its associated phalanges in the toes. The foot has 5 rays. The foot requires great stability to support the weight of the body above it and to absorb the shock of the ground beneath. It also must be rigid enough to propel the body through space by pushing off the ground. Flexibility allows the foot to adapt to the uneven ground surfaces it encounters. To meet these divergent demands requires the coordinated function of an entire complex of joints in the ankle region. The talocrural ankle joint is located between the distal tibia, fibula, and the talus. Because of this, the distal, middle, and proximal tibiofibular joints are involved in ankle joint function. The major tarsal joint in the foot is the subtalar joint, which joins the talus and the calcaneus. The transverse tarsal joint joins the talus, calcaneus, and navicular cuboid. All of the other tarsal joints are distal intertarsal joints and are named in each case for the specific tarsal bones involved. The tarso-metatarsal joints are between the tarsal bones and the metatarsal bones. The intermetatarsal joints are between the metatarsal bones. The metatarsophalangeal joints are between the metatarsal bones and the phalanges. Between the phalanges are the interphalangeal joints, with proximal interphalangeal joint between the proximal and middle phalanges of the toes, and distal interphalangeal joints between the middle and distal phalanges of the toes. The foot actually contains not 1 but 3 arches. The medial longitudinal arch is the largest in the foot and the one normally referred to when speaking of the arch of the foot. The medial longitudinal arch and the lateral longitudinal arch, which is not as high as the medial, both run the length of the foot. The third arch, the transverse arch, runs across the foot. The arch structure of the foot is not present at birth, but develops at about age 5. To detect pes cavus, or high arch, or pes planus, flat arch, simply observe a client's arch by taking an anterior view of the foot in a weight-bearing position. From a posterior view, a bowing of the calcaneal or Achilles tendon will indicate a dropped arch. You can also evaluate arches by spreading a small amount of oil on the foot and having the client leave a footprint on construction paper. The implications of unequal arches in feet are many. For one, the consequent height differential in the lower extremities can laterally tilt the pelvis, causing scoliosis in the spine. The foot has a thick layer of dense fibrous tissue on the plantar side known as the plantar fascia, whose purpose is to maintain and stabilize the longitudinal arches of the foot. There are 2 layers of plantar fascia, the superficial layer located on the dermis of the skin of the foot, and the deep layer which attaches to the calcaneal tuberosity posteriorly and the plantar plates of the metatarsophalangeal joints in the adjacent flexor tendons of the toes anteriorly. Plantar fasciitis is an inflammation that can tighten the muscles attaching to the fascia, placing tension on the fascia's calcaneal attachment, which can cause a heel spur. The condition often responds well to soft tissue work and hip strengthening. During walking, the foot toes off, extending the metatarsals at the metatarsophalangeal joints. Because the plantar fascia attaches to the toe flexor tendons, this motion pulls the fascia taut around the joints, making the foot more rigid while stabilizing and increasing the height of the arch. Similar to the raising of a ship's mast by the tension of a rope wrapped around a cylinder, called a windlass, this tightening and lifting of the plantar fascia wrapped around the metatarsophalangeal joint is called the windlass mechanism. Many retinacula run transversely across the ankle region, holding down and stabilizing the tendons that cross from the leg into the foot. Because the leg and foot are not in a straight line, but form an angle relative to each other, similar to the shape of a bow, the pull of the muscle lifts the tendon away from the ankle. This lifting away, called bowstringing, would diminish the strength of the muscle, reducing its ability to move the foot were the retinacula not there to resist it. Here's the objective for Lesson 8.5. The talocrural joint is located between the dome shape of the talus and the rectangular cavity formed by the distal tibia and fibula. The image of a wrench gripping a nut approximates the structure of the ankle joint. If comparing the ankle to a wrench gripping a nut, the malleoli of the tibia and fibula would be the jaws of the wrench and the talus would be the nut. The talocrural joint is structurally classified as a synovial hinge joint, and the talocrural joint is functionally classified as a diarthrotic uniaxial joint. The talocrural joint allows dorsiflexion and plantar flexion around the medial-lateral axis within the sagittal plane. However, because of the twisting of the tibia, known as tibial torsion, motion happens in an oblique plane. This motion is often labeled triplanar, which can be misleading, as triplanar indicates motion across all three cardinal planes. The talocrural joint, however, is uniaxial. It moves in one oblique plane around one oblique axis. The terms dorsiflexion and plantar flexion are used to avoid confusion regarding which ankle motion is flexion and which is extension. Technically, flexion is plantar flexion because that is the direction of flexion from the knee joint and further distal. Moving the ankle joint with the foot fixed produces a reverse action, in this case dorsiflexion and plantar flexion of the leg in the sagittal plane of the talocrural joint. The gastrocnemius, a plantar flexor of the ankle joint, crosses the knee joint posteriorly. When the knee joint flexes, the gastrocnemius slackens, which permits more dorsiflexion at the ankle joint. The thinness of the fibrous joint capsule provides little stability to the ankle joint, making the collateral ligaments more important to limiting frontal plane movement at the ankle joint. The medial collateral ligament, also called the deltoid ligament, attaches from the tibia to the calcaneus, talus, and the navicular bone. It is a taut, strong ligament. The medial collateral ligament limits eversion within the frontal plane of the foot at the ankle joint. The lateral collateral ligament is actually a complex of three ligaments, all of which attach proximally to the lateral malleolus of the fibula. Distally, the anterior patellofemoral ligament attaches to the anterior talus, the posterior patellofemoral ligament attaches to the posterior talus, and the calcaneofibular ligament attaches to the lateral surface of the calcaneus. The lateral collateral ligament limits inversion within the frontal plane of the foot at the ankle. Eversion springs of the ankle are uncommon because the lateral malleolus of the fibula extends distally far enough down to add to the stability provided by the deltoid ligament. Unlike the lateral malleolus, the medial malleolus does not extend very far distally, making the lateral collateral ligament the sole line of defense against inversion sprains. Inversion sprains usually occur when a person is moving forward, which couples a plantar flexion motion of the foot with inversion. The stress this places on the anterior talofibular ligament makes it the most commonly sprained ligament in the human body. The major muscles of the ankle joint include the muscles of the anterior compartment of the leg, the tibialis anterior, extensor digitorum longus, extensor hallucis longus, and fibularis tertius. The major posterior muscles of the ankle joint are those located in the lateral and posterior compartments of the leg, the gastrocnemius soleus, the tom, dick, and hairy muscles, and the fibularis longus and brevis. The posterior compartment muscles that cross the ankle joint medially are tom, dick, and hairy muscles. The lateral muscles are the fibularis muscles, longus, brevis, and tertius. This figure shows most of the bursa, retinacula, and tendon sheaths of the ankle joint region. The retinacula hold down the tendons that cross the ankle joint, preventing the tendon action called bowstringing. Tendon sheaths found around most tendons that cross the ankle joint minimize friction between the tendons and the underlying bony structures. The major joint between the tarsal bones of the foot is the subtalar joint. As its name implies, it is located under the talus, specifically between the talus and the calcaneus. The joint is also known as the talocalcaneal joint or the lower ankle joint. On the medial side of the foot, the talus is supported by the sustentaculum tali of the calcaneus. The sustentaculum tali is one of the two easily palpable landmarks of the medial foot. The other is the tuberosity of the navicular. Three separate taloccaneal articulations compose the subtalar joint. Each is a facet articulation, either slightly concave, convex, or flat in shape. The dashed lines in this figure indicate how the facets line up with each other. The largest articulation is between the posterior facets of the talus and the calcaneus. The sinus tarsus, a large cavity between the talus and the calcaneus, is visible from the lateral side. The subtalar tarsal joint is classified structurally as a synovial joint. Its functional classification is the diarthrotic uniaxial. Because it allows movement across all three cardinal planes, the subtalar joint is often called triplanar. However, its motion is in one oblique plane around one axis, so while it is triplanar, it is nonetheless uniaxial, like the talocrural joint described previously. Pronation and supination of the foot are axial movements in an oblique plane around an oblique axis. During closed chain activity, when the foot is planted on the ground, reverse action will medially and laterally rotate the leg at the subtalar joint. In Figure A, the foot pronates at the subtalar joint. This oblique plane movement comprises three cardinal plane components: eversion, dorsiflexion, and abduction of the foot. In Figure B, the foot supinates in the subtalar joint. This oblique plane movement comprises three different cardinal plane components: inversion, plantar flexion, and adduction of the foot. Different sources describe subtalar motion differently, but while some say eversion is pronation and inversion is supination, this technically is untrue. Eversion and inversion are the principal cardinal plane components of the larger pronation and supination actions. Figure C illustrates the frontal plane components of inversion and eversion. Figure D illustrates the sagittal plane components of dorsiflexion and plantar flexion. Figure E illustrates the transverse plane components of abduction and adduction. Determining the average range of motion in the subtalar tarsal joint requires that movements begin from neutral position. Not all sources agree on a universal neutral position, but numbers listed here reflect the idea that a subtalar neutral position would allow twice as much inversion as eversion. The anterior and middle aspects of the subtalar joint share a joint capsule with the talonavicular joint, but the posterior aspect of the subtalar joint has its own fibrous joint capsule. As their name indicates, talocalcaneal ligaments are located between the talus and the calcaneus. They limit eversion of the subtalar joint. The cervical ligament runs from the talus to the calcaneus within the sinus tarsus, where it limits inversion of the subtalar joint. Important to the transverse tarsal joint, the spring ligament also helps stabilize the subtalar joint, limiting eversion. It spans the subtalar joint inferiorly on the plantar side. The transverse tarsal joint runs transversely across the tarsal bones. The transverse tarsal joint is a compound joint composed of two joints that are collectively called the transverse tarsal joint. The talonavicular joint is located between the talus and the navicular bone, and the calcaneocuboid joint is located between the calcaneus and the cuboid. The talonavicular joint is much more mobile than the calcaneocuboid joint. Motion of the subtalar joint requires motion at the transverse tarsal joint. In fact, both joints have the same name motions that occur. The transverse tarsal joint is also known by Chopart's joint, or the mid-tarsal joint. The ligaments of the transverse tarsal joint help to stabilize the joint and help to indirectly limit motions, thereby stabilizing the subtalar joint. The talonavicular joint of the transverse tarsal joint shares the anterior joint capsule of the subtalar joint, but the calcaneocuboid joint has its own joint capsule. The spring ligament forms the floor of the talonavicular joint. The bifurcate ligament is a Y-shaped ligament of which the medial band is also known as the lateral calcaneonavicular ligament, and the lateral band is called the calcaneocuboid ligament. Here's the objective for section 8.6. The tarso-metatarsal joints are located between the distal row of tarsal bones and the metatarsal bones. The second ray of the foot is the central stable pillar of the foot and is the least mobile of the rays. It is the reference line for abduction and adduction of the toes. The tarso-metatarsal joints are numbered from the medial to the lateral side of the foot as TMT joints numbers 1 through 5. Dorsiflexion occurs when the distal end of the metatarsal moves dorsally. Plantar flexion is the opposite motion. Inversion occurs when the plantar side of the ray turns medially toward the midline of the body. Eversion is the opposite action. The fibrous joint capsules and the dorsal plantar and interosseous TMT ligaments stabilize the TMT joints. The intermetatarsal joints are located between the metatarsal bones of the foot as seen here in this figure. There are both proximal and distal intermetatarsal joints where all 5 metatarsal bones articulate with each other. This plantar view illustrates the ligaments of the plantar surface of the forefoot, including the plantar intermetatarsal ligaments of the proximal intermetatarsal joints and the deep transverse metatarsal ligaments of the distal intermetatarsal joints. The intermetatarsal joints are plain synovial articulations. Motion at a tarsometatarsal joint requires the metatarsal bone to move relative to the adjacent metatarsal bones. Therefore, intermetatarsal joints are functionally related to tarsometatarsal joints. The metatarsophalangeal joints are located between the heads of the metatarsals and the bases of the proximal phalanges of the toes. They are numbered from the medial side to the lateral side as MTP joints 1 to 5. The MTP joints are synovial joints, and they are diarthrotic. These illustrations show flexion and extension of the toes at the metatarsophalangeal and interphalangeal joints. Flexion and extension of the toes at the metatarsophalangeal joints are axial movements that occur in the sagittal plane around the medial lateral axis. Abduction and adduction of the toes also occurs at the metatarsophalangeal joints. Because the reference line for abduction and adduction is an imaginary line through the center of the second toe when it is in anatomic position, Toes 1, 3, 4, and 5 abduct away from the second toe and adduct toward it. The second toe abducts in either direction it moves. Figure E shows fibular abduction of the second toe at the metatarsophalangeal joint, and figure F shows tibial abduction of the second toe at the metatarsophalangeal joint. The fibrous joint capsule of the metatarsophalangeal joint is stabilized by collateral ligaments and the plantar plate. The collateral ligaments are the medial collateral ligament and the lateral collateral ligament. They are thickenings of the joint capsule located on their respective side of the metatarsophalangeal joint. The plantar plate is a fibrous tissue structure located on the plantar side of the metatarsophalangeal joint. Its main function is to protect the head of the metatarsals during walking. This figure illustrates the fibrous capsule, collateral ligament, and plantar plate of the MTP joint. These structures are also illustrated for the PIP and DIP joints. Hallux valgus is a deformity of the big toe in which the big toe deviates laterally at the metatarsophalangeal joints. It also often involves a medial deviation of the first metatarsal and causes increased stress, resulting in inflammation of the bursa located there. This can eventually result in fibrosis and excessive bone growth on the medial side of the first metatarsal's head, which is called a bunion. The interphalangeal joints, pedis, are located between the head of the more proximal phalanx and the base of the more distal phalanx of the toes. The words pedis, denoting foot, and manus, denoting hand, are used to distinguish between these interphalangeal joints. The big toe has only one interphalangeal joint, but toes 2 to 5 each have two interphalangeal joints, a proximal interphalangeal joint, PIP, and a distal interphalangeal joint, DIP. The interphalangeal joints pedis are synovial joints and are diarthrotic. Flexion and extension of the toes are axial movements within the sagittal plane around the medial lateral axis. The reverse action is moving the more proximal phalanx of a toe relative to the more distal one. The closed packed position of the interphalangeal joints is extension. This concludes the first part of our lecture for Module 3.